Welcome, everybody. Great to have you here with us. And for those who haven't met me before, I'm Alice. I work in the Overcome Support Service. And today's session forms one of our webinar series. We have been really busy with webinars recently, which is brilliant. And we try to, put out sessions on all sorts of aspects of living with ovarian cancer, whether that's kind of research related, advancements in treatment, or kind of adjacent areas that relate to living with cancer and the impact of that in all sorts of different ways. Really briefly, I know most of you are probably fairly familiar with Overcome, but you can, of course, get in touch with our support team via phone, via email. We have our busy My Overcome forum as well, which has now just past 20,000 members, which is fantastic. So a really great source of information and connection there too. And of course, we have our suite of support groups and workshops as well, which run throughout the week. As well as that, on about a monthly basis at the moment, we are trying to get out and about across the UK. So if you'd like to come and meet people in person, we love hosting those events. We have 2 more planned in for 2026, and then we'll be back out next year visiting more locations. So all of this information can be found on our website. If there's anything that you're looking for and you can't quite put your finger on it, then just get in touch. We're a small team, so we'll make sure your question goes to the right person. We're really thrilled to be joined today by Dr. Shibani Nicum. And I must say, as I was writing out my sort of introduction for Shibani, I thought, oh my gosh, there's so much here that I want to sort of touch on. So Dr. Shibani Nicum is a consultant medical oncologist and an associate professor of medical oncology at University College Hospital, London, specialising in the treatment of women with gynecological cancers. She trained at the Royal Marsden and is currently the chair of the National Cancer Research Institute Gynecological Group, lead for gynecological trials at Cancer Research UK, and also at UCL Cancer Trials Centre. In addition to this oncological practice, she is also leading the development of services and research to improve the care of women with treatment-induced menopause. She's a member of the All-Parliamentary Party Group led by the Menopause and Ovarian Cancer Select Committees and the British Gynecological Cancer Society Menopause Guidelines Consensus Group. So I'm sure you'll agree is extremely well placed, to be facilitating this session today. I'm not going to go into much detail about, what Shibani is going to be covering. But we're just extremely grateful for your time today, Shibani, and thank you so much for your efforts in preparing the session and for joining us today. I'll pass over to you now.
Thank you, Alice, for the introduction. It makes me sound very fancy, but essentially I'm a medical oncologist and a doctor who specialises in caring for women with ovarian cancer and other gynecological cancers. And a big part of our care now is also thinking about how we manage how you live well following that treatment and from some of the side effects of the treatment that you've had. And menopause actually is a big part of that for many women. And so this session is really timely because I think it gives you a little bit of an update on where we are with our thinking and hopefully empowers you to ask your consultants if you haven't had management of your menopause. So I'm going to share my slides now. And it should be about half an hour for the talk, but please do put your questions in so that we can have a good discussion at the end. Oops.
Yeah, we've got the slides. Perfect. Yeah.
Can you see that okay?
Yeah.
Okay, great. So the session today is really thinking about menopause management after ovarian cancer treatment. And it's not moving ahead. There we go. So really just to try and put this into context. So menopause induced by cancer treatment can have a significant impact on your health and quality of life. And Macmillan have estimated that around 60,000 women in the UK develop cancer treatment-induced menopause. And this can actually be much more abrupt than women who go through what we call a natural or non-complex menopause. And it can also have impacts on your longer term health in terms of your heart, bone, brain function, sexual function, and your mood. And for many women who are taking endocrine treatments like letrozole or Zoladex, they may not actually be in menopause, but they have a menopause-like syndrome. And this can actually worsen symptoms for those who have gone through menopause as well. So, treatments that we give you may make those of you who have been through menopause develop worsening symptoms. So when we think about what the menopausal symptoms are, the common things are things like hot flushes and night sweats, but it can impact your memory, your joints with pains in any of the joints. It can decrease libido, so impact your sexual health, have changes in your mood, brain fog, anxiety, sleep disturbances, and this sort of syndrome that we call urogenital, and that really is sort of vaginal, vulval dryness or problems with the kind of urination, urinary frequency, um, and incontinence. So this syndrome can take place anywhere because you basically have estrogen receptors all around the body. So when there is a lack of estrogen, it can impact these different organs and these different areas of your health. And that's why we call this kind of a syndrome of menopause. The treatments that we give you, so surgery, if you remove the ovaries, chemotherapy, radiotherapy, and hormone and targeted treatments, so hormone treatments like letrozole, tamoxifen, targeted therapies, even things like immunotherapy, may make some of those symptoms worse. And as oncologists, we are often very, very focused on your cancer, the impacts of your cancer treatment, the side effects and symptoms. And some may not even recognize that this could be this sort of underlying menopause that's also worsening some of the treatment effects. So, hang on a sec. Okay. So, sorry. There are also particular groups that may face barriers in menopause care. So there may be sort of cultural taboos around discussing menopause. There could be language barriers. There could be a lack of awareness of symptoms and screening. And so it may be that certain groups of women actually suffer more from these menopausal symptoms. These slides are looking a little bit out of context. And these symptoms of treatment-induced menopause, the symptoms can sometimes be worse, as I mentioned, if you undergo sort of abrupt menopause through surgical removal of your ovaries, if you've had previous chemotherapy, and also if you have gained weight during your treatment, it could actually worsen some of your menopausal symptoms. And we know that, particularly in the breast cancer space, but also in other cancers, that many women will stop their anti-cancer treatments due to unmanaged menopausal side effects. So it's really important if you are having side effects to discuss this with your oncologist, as there may be different options that you can be considered for. It may be that you're eligible for HRT or some non-HRT options, or it may be that they can switch around some of the treatments that you're on. So if you're on these sort of endocrine treatments like letrozole, sometimes switching between different ones can actually improve your symptoms. So when we're thinking about how we're going to manage your menopause, these are some of the questions that we'll be going through our head, and we'll be managing and we'll be looking at some of this with you. We'll be looking at what menopause symptoms you have, how severe those symptoms are, what treatment you've had. So is it that you've had your ovaries removed, had your uterus been removed, because that can sometimes impact the type of HRT that we give. What type of cancer do you have? So is it what we call a low-grade cancer or a high-grade cancer? What's the subtype of the cancer? So we know there are many different subtypes of cancer, of ovarian cancer. So there's serous or clear cell. And this again may impact the decision-making around the safety or use of HRT. We'll also want to know if your cancer expresses the estrogen receptor, because if it does that put you at increased risk if we then give you estrogen type HRT? We'd want to know whereabouts you are on your cancer journey. So is this very early cancer that's been treated? Are you many years out, a few weeks out from your treatment? And also whether you carry any genetic risks. So there may be certain hereditary factors, like if you carry the BRCA or BRCA gene, that may put you at increased risk of other cancers that we may just need to think about if we're considering HRT. If we do think that HRT may be safe for you, then there's certain factors around the prescribing of HRT that we need to think about. So thinking about your blood pressure, whether you've had blood clots or whether there's risk of blood clots, if you've got a history of migraine or any other problems such as liver or any other sort of medical problems that we need to think about. And of course, we need to really consider what your patient preferences might be. So when we present you with this sort of information and risk benefit ratio, what is it you would like? Some women know very clearly that, their symptoms are so terrible that they want to try HRT. Others really want to avoid any kind of additional risk. So having this sort of conversation about where it is that you are on your journey, what your preferences are, can really help us to help manage your symptoms. So it can be really, really complex, essentially. And we need to think about how we can help doctors who are managing your menopause provide you with the most up-to-date and personalized advice. And one of the reasons we did this, we developed an app. I work at UCLH and my team led this, but we have a national group of experts who include menopause specialists, GPs, patients, and other oncologists, both breast and ovarian cancer specialists. And really what we wanted to do is be able to take clinicians, so it might be your GP, it might be your oncologist, it might be people within the GP service, such as pharmacists that are helping to manage your menopause. And what we wanted to do was to give them some kind of framework around the flows that I just showed you that would help make decisions and also then help you feel that you've received really the most up-to-date advice that's been personalized for your particular condition. And I'm just going to show you the app that we've developed for clinicians. So we initially started this really based around cancer-related menopause. And so we wanted to do it really for the gynecological group of patients, so patients with ovarian, endometrial, cervical cancers. But actually, as we started to work with patient groups and GPs and the wider healthcare professionals, we realized that there was a huge need for many different groups of women. So those who undergo natural menopause, those who undergo a very early or premature menopause, so that's women below the age of 45, and also those who undergo risk-reducing surgery. So we understand now more about hereditary conditions. We're testing for BRCA, and many women are below the age of 40 when they undergo removal of their ovaries to try and safeguard them from developing ovarian cancer. And we also wanted to support clinicians to have a wide range of treatments, not just HRT on offer, and also deal with the complications. So the app covers all of this and much, much more as planned. So I'm going to show you a little bit about how it works because it then becomes a little bit clearer and it's something you might want to recommend to your GPs and other clinicians. So you can click onto the menopause library and then your clinicians would move into the cancer-related menopause space and scroll down to the section that relates to you, which would be ovarian cancer. So once they click on that, they can then go on to the management section. And what we give them is the fact that this has all been taken from national guidelines, so the BGCS and BMS guidance. They can then click on the subtype of cancer, how advanced the cancer is, so stage 3, what type of symptoms, if they're systemic, and you can actually come out with a decision of it may be safe to consider HRT. And we give them a list of considerations when they're thinking about whether it would be the right thing for you based on your tumor status, the severity of the symptoms, your wishes. If you want to start with non-hormonal treatments, it will take them to a table which helpfully compiles all of the non-HRT, so non-estrogen type therapies that may be available. If they think actually HRT is the right thing, we'll guide them to prescribing. So some of the risk factors for using HRT, whether you've had a hysterectomy or not, any history of endometriosis. So all the sort of factors that we consider as doctors when we decide the type of HRT. So it might be that we give you just estrogen. For the majority of you, that would be safe. For some women, we may want to add progesterone. And again, it takes you through how to prescribe it and what to do if you have side effects on treatment. And this is actually, comes from my own personal need. So a few years ago, before I started getting interested in this field, actually, I was used to developing many different cancer drugs. I was used to developing clinical trials and leading, many toxic therapies into kind of clinical care. And yet, when one of the surgeons asked me to prescribe estrogen for a lady that I was treating when I next saw her, I really went into a bit of a tailspin because I had no idea how to prescribe it or what factors I needed to consider. And I thought if I felt like that, it was probably that many people felt like that. And a survey by Target Ovarian Cancer did actually show that 70% of women who had had treatment for ovarian cancer had never really been asked, or the menopause hadn't really been discussed, and they hadn't been asked about their symptoms, and it wasn't really being managed nationally. So we know there's a need not only to realize that there are symptoms that need to be treated, but actually we need to support the clinicians that are caring for you in delivering that care as well. So we'll move on to the next one. So what we're hoping is that by using this app, your clinicians will be able to confidently manage menopause because we bring together all the latest guidance. So this is the main guidance, so the BGCS, BMS, and the NICE guidance, so all national guidance. We're trying to bring everything in one place because a lot of this exists, but on multiple different websites. It can take an hour to get through to make a decision. But actually, we saw there in under a minute, we can make a decision confidently about what the national guidance is on the safety of HRT and also to make prescribing decisions. We do also cover a lot of complementary therapy, so the use of yoga, the use of CBT, so cognitive behavioral therapy. So lots of sort of a range of treatment options. And what we really wanted to do was to be able to simplify those really long guidelines and condense them into sort of an easy to use guide for clinicians to really be able to provide the most personalized and patient-centered treatment. And the good news is that we also have now a companion app which we're developing together with the East Midlands Cancer Alliance, and that we hope will be available for you all as a web page or a web app, which will have information around some of the lifestyle advice, but also around some of the decision making around HRT. And we're really interested in hearing from you if there's things that you would like included on this. We've obviously got a minimum setup that we're going to start with, but actually we want to develop this further. And it maybe then it's just providing links to guidance that's already out there, but clearly a need for this sort of dual-pronged attack where we actually think about the clinicians and supporting them to help you, but also how you can support yourself and how you can be empowered to discuss this also with your clinicians. So I just wanted to highlight some of the guidance that there is. So in 2024, a group of us experts, so menopause experts, experts in caring for gynecological cancer, so that included surgeons and oncologists and patients, came together to really try and bring together and review all of the evidence there was in gynecological cancers. And we developed this guideline, which you can log on and have a look at if you're interested. So this is a joint guideline, a consensus statements from the British Gynecological Cancer Society and also the British Menopause Society. And these tables, the next couple of slides, there are a couple of tables which just help to summarize some of that information around the safety of estrogen and progesterone HRT. So this is sort of all of gynecological cancers, and we can see in the top three are kind of ovarian cancers, so our epithelial ovarian cancers, low-grade and granulosa cell cancers, and germ cell cancers. And within the epithelial group, there was a moderate level of evidence about the use of HRT. It was mostly sort of information that was from quite old studies. There were small studies. They use older forms of HRT, but all of that evidence and a big Cochrane meta-analysis review seemed to not show any increased risk of cancer recurrence in women with epithelial ovarian cancer. And so the guidance that we and also others, this is from a Lancet review by Martha Hickey, was actually that in epithelial ovarian cancer, it may be safe to consider HRT, but you may want to consider non-HRT options first, and if those aren't helpful, then consider HRT. Some cancers, like the low-grade cancers, particularly, are driven by estrogen. So we know that having higher levels of estrogen drives the growth of some of these cancers or the recurrence of some of these cancers. And there was really not very much evidence of the safety of these drugs in this group of patients. So there wasn't really a high level of safety with the use of HRT. And so the consensus internationally is for this group of women, we would avoid HRT except in exceptional circumstances where the symptoms were very severe, and it would be on a very case-by-case basis. Again, the germ cell tumours, these are very rare tumours, and therefore there wasn't a lot of evidence about the safety or the risks of HRT in this group of women. And again, here the guidance was to consider it, because often these women may be very, very young, and it may be that the benefits of HRT outweigh any of the risks or potential risks of recurrence. So we also developed a table for this guideline, which helped, again, at a glance, help clinicians to be able to look at the different groups of ovarian cancer. So we broke down all of these groups of ovarian cancer or fallopian tube or primary peritoneal into the subtype and gave a risk assessment based on a very simple traffic light system, where we use green for saying it was safe to be considered, red to really avoid it, and yellow was this sort of group where there wasn't a lot of evidence, but it didn't seem to be any evidence that it increased the risk, and actually the risks may not be very high with HRT, with all the provisos that I've said. So you can see that for the majority of women, actually vaginal estrogen, where you're giving estrogen very topically for the treatment of vaginal dryness, and it may also help with things like urinary incontinence or repeated urinary tract infections. Sometimes actually this lack of estrogen vaginally can be a key cause of that. So for the majority of women, except for that sort of group of women with slightly more advanced low-grade cancers, it was a sort of a green for kind of can be used and should be considered in this group of women. For the systemic HRT, so this might be patches or gel or sprays of estrogen plus or minus progesterone, that's what we mean by HRT. It was, again, for certain groups, it was relatively safe based on the evidence to consider HRT. The majority of women, we wanted clinicians to just consider the use, but also then think, are there effective non-HRT options that may be safe to use in this group of women as well? So when we talk about non-HRT options, this is a sort of table, and it's a summary of the table that's also available within the app. And the majority of these, other than the fezolinetant and elasinitant, have not really been developed for the use of menopausal symptoms, but actually can have some beneficial effects. Now, the thing about giving HRT when you give estrogen, it really helps all of the sort of symptoms of menopause for the majority of women. So it can help your hot flushes, it may improve things like brain fog, it may improve vaginal dryness, sexual issues, mood. All of those things are likely to be helped by estrogen and getting the dose of estrogen right. With the non-HRT options, we're often thinking about using one or two different ways of managing your menopause, because they may be helpful for one section, but may have some side effects or may not be helpful for all of your symptoms. So it's often picking the symptoms that's causing the most disruption to your life and really trying to focus on improving that, and then using other measures together with that to try and manage your symptoms. So we have this sort of group that are typically used. So that might be the group of antidepressants, so things like venlafaxine and citalopram. And you can see here that it helps with things like hot flushes and night sweats. It doesn't really help with vaginal dryness, and it can actually make sexual dysfunction worse. You've got groups like oxybutynin, which is probably one of the more effective treatments. And again, it helps with hot flushes and night sweats, but it's unlikely to really help with vaginal dryness. So it may be that if you use these and you have vaginal issues as well, that you might be thinking of using things like a vaginal moisturizer and a lubricant during intercourse as well. It may be that we combine this with other factors, so things like cognitive behavioral therapy, which can be really helpful for sexual dysfunction, stress management, anger management, vasomotor symptoms like hot flushes and night sweats. and also combining it with physical exercise, so yoga, which helps also with mindfulness and stress reduction. And it may be things like acupuncture and hypnosis can also be helpful. And hypnosis and this combination of hypnosis and cognitive behavioral therapy seems to be a very effective combination based on some recent information. So it's really considering all of the options when you're managing menopause. It might be that HRT is the thing for you, or it might be that it's using non-HRT options. And you can then also be thinking about other things in terms of how we manage with, for example, supplements. So are there over-the-counter things that may be helpful, like sage or vitamin D? What's your sleep hygiene like? So, can we manage your sleep better? There are some apps that have been approved by NICE, which is the sort of regulatory body for the NHS. There's one called Sleepio, which is meant to be very helpful. It's like a cognitive behavioral self-help app. There are complementary therapies, like I mentioned, acupuncture that may be helpful, cognitive behavioral therapy, and also lifestyle factors. So things like moderate exercise, weight loss, avoiding spicy food, avoiding alcohol, stopping smoking can be really helpful. And so I kind of summarize this in thinking that HRT is much more than just, menopause management is more than just HRT. It's sort of non-hormonal options that may be helpful for you. It's encouraging you to raise concerns about sort of other factors that may be associated with menopausal symptoms, so your sex lives and vaginal dryness. Thinking about you being able to have a conversation about what your risks and benefits of having HRT might be, and thinking about what other resources through the charitable groups and also things like Maggie's, who run a Menno crash course, and also things like Macmillan, who are also doing a lot of work. And I know all of the charities, including Overcom, have a lot of help and information as well around menopause. So thinking about menopause really as some of the pillars of health. And this is a kind of a general slide, and it would need to be modified based on your sort of current health, about where you are in your cancer journey. And it's always best to get advice from your doctor, your oncologist, before you embark on a big life overhaul. But some of the pillars and things that you can be thinking about. So we want to be thinking about your bone health. So if you're below the age of 45 and you've gone through menopause, or you've got menopause induced by your cancer treatment, you want to be thinking about your bone health. So what can you do for yourself in terms of, weight-bearing exercise? So this is things like walking, or running, or jumping. So anything that stresses the skeleton. So things like swimming are really helpful for many other things, but they don't really help your bone health. So really trying to get a little bit of weight-bearing exercise, even if it's a short walk. You don't need to be doing 10,000 steps. Even 10 minutes every day, and increasing that slowly as you can manage. 5-10 minutes is all really good for the skeleton, and actually for your bone health. Thinking about taking a course of vitamin D. So it might be that just an over-the-counter dose, a lower dose of sort of 800 to 1,000 international units is good during the winter months. Stopping smoking, reducing alcohol, all help with your bone health. And if you're below the age of 45, really thinking about getting a bone scan to see where your bone health is as a baseline when you're on your treatment or just finished your treatment. We need to also be thinking about your cardiovascular health. So what's your cholesterol doing? Can we manage that and modify that? What's your glucose levels like? And again, sort of managing blood pressure. And some of this may be being done anyway routinely if you're on therapies through the hospital, but it might be something your GP could do otherwise. You want to be thinking about your nutrition. So sort of making sure you have a balanced diet as you're able to, and also thinking about exercise and managing weight, as we've mentioned. So some of these things, it's not that everything can be done in one go. It's just pacing yourself and thinking about sort of menopause and life after cancer treatment as many different areas. And it's making small improvements and doing small things every day. It's not that you need to sort of overhaul your life all in one go. It's these small steps can actually add up into really big benefits. So I just wanted to pick up on a few of the different symptoms that are very typical for menopause. And just these are things that I commonly get asked about in the sort of cancer menopause service, the patients that I see. So many of them will be suffering from hot flushes and night sweats. And when we use HRT, often within a few weeks, they will feel better. For those women who don't want to have HRT or who are advised against having HRT, we use agents such as venlafaxine or citalopram. And I put in fezolinetant because this has newly been approved, and this is a agent that has been specifically developed for the management of hot flushes. So the first agent that's reached the market that's been specifically developed for women who can't have HRT or don't want to have HRT. There isn't a lot of data in cancer patients with this agent, but it is being used, and we have about 2 years of data, and we have 30 or 40,000 patients in the US who have received this, who have a cancer diagnosis. So there is increasing information. There are trials ongoing in the gynecological cancer space with ovarian cancer patients, and so we hope we'll have more information. But it is something that has been approved by NICE, and some of the menopause specialists and GPs are much more comfortable about using many of these agents off license after they've discussed the risks and benefits with you. And it's something now in the cancer menopause MDT that I lead at UCLH that we are now considering for certain groups of women. So it's always worth asking about this and whether this might be an option for you. There's some general things that you can do. So manage your weight, think about exercise, and it may be that other therapies such as cognitive behavioral therapy, hypnosis might be helpful as well if the other things have not helped. So this is just some information on these agents, fezolinetant and elasinitant. They are specific agents and they target two receptors. They target both the NK1 and the NK3, and they stop these group of neurons called the KNDY or KNDy neurons, which basically are within the brain and are usually bathed in estrogen. And as the levels of estrogen fall in the body, they keep firing and can cause the hot flushes and night sweats that are typically associated with menopause. After a while, they do understand and they realize and they adapt to the low estrogen environment. And that may take a few months or a few years for some women. So in that interim period, you'll be sort of suffering with hot flushes and night sweats. So these agents directly bind and target this particular neurons and inhibit them from firing off. And the trials have shown about a 50% reduction in these moderate or severe hot flushes at 4 weeks. And they've looked up to 12 months and women continue to derive benefit. And we've got evidence of the safety of the second agent, elasinitant, in breast cancer patients who are currently on agents such as letrozole. So we think there's no specific reason why these agents should increase the risk of cancer returning. So I think it is going to be an important class of drugs for managing hot flushes and night sweats. And NICE, as I say, have approved this in the non-cancer population, but many menopause specialists are thinking about using this. So sleep is often very disrupted. And there are often multiple causes for this. So it could be the hot flushes and night sweats are waking you up. It could be due to kind of anxiety, this fear of recurrence, fear of where you are in your treatment. So there can be many things that can be impacting the sleep. So it's really important to take a good history when we meet you, to think about what the causes might be for you as an individual, and then think about the most effective treatments. And it may again be a combination. So it may be that we decide to give HRT or think about other non-HRT agents that can cause drowsiness that you then take at night that manage things like your hot flushes and night sweats. It may be that you combine that with cognitive behavioral therapy and also self-help apps such as Sleepio, which I've already mentioned. Other helpful options can be things like acupuncture, cognitive behavioral therapy and hypnosis, and also meditation have been found to be helpful, not just in managing sleep, but just overall reducing stress and helping to manage some of the impacts of the cancer diagnosis. I just also wanted to mention some of the sexual impacts of cancer treatment, because I think this is a really hidden and often under-discussed impact of cancer treatment. The physical changes, as you're aware of, not just menopause related. There may be sort of low sex drive due to reduced kind of pleasure, due to changes in your kind of body, the way that you feel about your body. There may be vaginal dryness and discomfort associated with intercourse. maybe huge emotional and psychological impacts of the cancer, as well as the menopause on top of that. And that can really impact relationships. So some of the things that we try and do in our practice, and when I see patients who come to see me regarding their menopause, cancer treatment-induced menopause, is to really think about all of these factors that may be underlying it. And again, trying to think of a holistic way of addressing all of those things. So it might be that we recommend vaginal moisturizers. The one that I particularly recommend is Yes. It's one that's available over the counter. Many of your oncologists may have samples and things of this in the department of nurse specialists, so it's always worth asking. Also, the use of vaginal lubricants during intercourse for both yourself and your partner. Thinking about counselling and psychological support around any things that may be troubling you, and also thinking about psychosexual counselling and also, again, cognitive behavioural therapy. I mentioned testosterone because I think, again, this is one of the things that I get asked about a lot. And the general guidance around testosterone is that there's very limited evidence of the safety of testosterone in patients who have had a cancer diagnosis. We know that testosterone is converted in your body to estrogen. And so if we would not recommend estrogen HRT, we generally would not recommend testosterone either. In non-cancer settings, the national guidance is to use it only for women who have a low sex drive. And it is being used in extended ways for women with brain fog and fatigue and, problems with the kind of muscle strength. But actually, there's very limited evidence for its effectiveness here. Some women will say it's made a huge effort. In others, they find it doesn't really make much of a difference. There can be side effects, particularly if you use it without estrogen, and you can get an increase in what we call androgenic or male type side effects. So you might find excessive hair growth, chin hairs, acne, weight gain. It's usually reversible once you get the dose reduction or you stop it. Some women can also see that their hair starts to thin. It can deepen their voice. And again, this is rare, but it is a sort of potential side effect, particularly when you give testosterone without estrogen and if the dose is a little high. So some of the practical considerations, if you are being considered for testosterone, is that you get your total testosterone levels measured before you start, and then around sort of 6 to 12 weeks after you've been on the treatment, and then sort of 6 to 12 monthly, depending on how it is. Most of the preparations in the NHS are things like Testim and Tostran and Testogel. These are licensed for use in men, but are used off license in women. There's one, Androfem, which is licensed in Australia for women, so it's specifically formulated for women. It's probably not that much different, but it's now available in the UK under a private sort of NHS. So it's not available on the NHS, it's only available through a private prescription. But that is one that is specially formulated for women. So I just wanted to conclude by saying menopause treatment in cancer patients can be very complex. There's often quite limited longer term information that can make decision making difficult. But it is important to consider it still. And it's often this balance of what your symptoms are and what the risks of your cancer coming back on. For those who are on non-HRT, it's important to realize it might take 3 to 6 months to see a benefit. So really persevering on that treatment. It might be that we use a very holistic stepwise approach where we try and manage the most troubling symptoms worst. We start with simple interventions that aren't increasing risk. Also thinking about how we support you psychologically. What are the other impacts of your cancer diagnosis? Cognitive behavioural therapy may really be helpful for many women. And there may be, that you've gone to see different people and they've given you different advice. And that's really because there's not a huge amount of evidence. And so often it's based around people's opinion or their experience. But hopefully you'll see now we have specific advice based on sort of expert consensus with the BGCS BMS guidance. We've got the app, which will really help clinicians to be able to implement that guidance in your consultations so that they can actually personalize that for you in real time and actually help to deliver sort of tailored care. And if you can't get that just from your team, your oncological team, do mention the app to them. That maybe that helps them to support you. And it would then also be helpful maybe for some of you to see a specialist who has experience in managing menopause in cancer patients. So, thank you very much for your attention. These are a few links to the Menopause app, which we will have a patient-facing app that's in development at the moment, and we hope in the next 3 to 6 months that will be live. We have an Instagram page which will keep you updated. We've just started this in the last week or so, so do log in to Instagram and follow. And if you've got things that you would like to see, any comments, we will be monitoring that really closely and hoping to make sure that this resource really meets the needs of everybody that needs it, particularly for this cancer cohort of patients who really struggle to get safe, personalised advice. So thank you very much. I'm going to stop sharing that now.
Brilliant. Thank you so much, Shibani. That was a really wonderful presentation. So much learning. I'm always learning in these webinars, but really clearly presented information about what, as you say, is quite a complex area. Thank you to those who've already put some questions into our chat as Shibani was working through her presentation. We have got a bit of time, so if anything else has occurred to any of you that you would like to ask, you can use the chat or the Q&A function, both of which should be somewhere at the bottom of your screen if you're using a computer. We'll fire away with the first question. So somebody's asking, I'm in my late 50s and thought I'd pretty much gone through menopause. I've had surgery, chemotherapy, and now I'm on inhibitors. However, I feel like I now have hot flushes more. Is this usual?
Yeah, so that's a really important thing because a lot of menopause, and one of the reasons why I think in ovarian cancer it really wasn't being addressed, is that it often happened to women who had gone through menopause. So it's a kind of post-menopausal cancer. That's how it was perceived. And we know now there's many younger women also developing it. And because of that, we never really worried so much about the fact that they might actually get worsening of their menopausal symptoms because the ovaries can actually still produce a very tiny amount of estrogen. And so when you remove the ovaries and you've had surgery, actually that tiny amount of estrogen that you have overnight gets lost. And so you can get a worsening of your menopausal symptoms, even if you are postmenopausal and even if you're many years postmenopausal. So it's quite possible that you've had a worsening of your symptoms. We find that it probably peaks at around 3 months and then over time improves. But we are doing a study at the moment, which is looking at exactly that, looking at how long those symptoms go on for. Because in ovarian cancer and in gynecological cancers, there's very little information as to, so we can't even guide you to say, look, don't worry, over the next 12 months, you'll find this improves, or let's manage this proactively. But the MDT that we run, we found that 15% of the women that we discuss are actually in the postmenopausal space. So you're absolutely not alone. And this probably is something to do with the fact you've had surgery and that estrogen has now completely plummeted. And that's why you've got a worsening of your symptoms. So it is actually pretty typical.
Okay, interesting. Thank you. The next question is somebody asking, how do I find out about the hormone status of my cancer? They've said, I'm a high-grade clear cell carcinoma patient. I only know really that my menopause is post-surgical. I suppose the question is that something that should always be communicated, the hormone status of someone's cancer? If someone isn't sure, what can they do to find out about that?
Yeah. So often when you are diagnosed, the pathology report will look at a number of different factors to aid the diagnosis of your cancer. And we also typically do estrogen receptor status on the majority of ovarian cancer samples and patients as well. So even if you don't know it, if you ask your oncologist, they will be able to look back at your pathology report and check whether your cancer was estrogen receptor positive or not. If it hasn't been done, they can usually request it from their pathologists as well. So you should be able to find that out directly from your oncologist. It's not likely to be something your GP can help you with. So I would recommend going back to your cancer teams, nurse specialists, oncologists, because they should be able to help you with that. And with clear cell cancers, because they're often endometriosis related, they would also be able to look and see whether there was a significant history or diagnosis of endometriosis as well. So, yeah, that's best place to start.
Brilliant. Thank you. The next question is a food related question. So somebody's asking you, do you tend to recommend fermented foods? I've been advised to avoid these and other foods, for example, soft cheeses, kefir, smoked fish, things like that. So I don't know if you can answer to that one, Shibani, around kind of those food groups.
Yeah, so what I tend to do is when I'm taking a history, I would be mindful of where you are. So, do you have any symptoms from your cancer? Sometimes we would say for those that are having a lot of bowel related symptoms to avoid a lot of fiber, etc. If you're on active treatment, we ask you not to take anything with too many live cultures. So that might include things like kefir or live cultures, soft cheeses, things like this, because you can get an increased risk of infection from them. So it really very much depends on where you are in your cancer journey. If you're many years out, we would look at your kind of diet as a whole and think about the recommendations we make. So that's why I kind of put that proviso on that it's really important that if you are thinking about big changes in your diet, to introduce them slowly and speak to your doctor or your nurse specialist before you make any big changes, and follow the advice from your clinical teams. So if they've told you to avoid certain things, that would override that, because some of the advice I gave is some general advice that
Mhm.
we would use for cancer patients, but also for non-cancer patients. But it's always worth asking those questions, depending on where you are in your sort of cancer journey, as to what would be appropriate for you. And if your teams say to avoid those things, I would definitely go with their advice.
Mhm. Well, thank you. Yeah, getting quite a varied range of questions come in, which is fantastic. The next one, somebody's saying, I recently read that menopause can cause thinning of the gut wall that results in lots of women going on strict diets due to apparent food intolerances. It's not normally listed as a menopause symptom. So is there any basis to this? Or was it just a sales pitch from a company selling collagen supplements?
So, what I'm seeing now increasingly is that if you label anything as a menopause, so menopause related hair care, menopause related supplements, collagen, etc. It really sort of targets a group of women that are quite vulnerable, actually, I think. Menopause has so many changes to your body because of the lack of estrogen. And we're all really reaching out and hoping that something is going to help. So I personally think if you want to take a supplement, the sort of things I recommend is a multivitamin. Simple from Boots, nothing fancy. It might be that vitamin D is helpful. Magnesium can be really helpful for sleep. And everything else, it's really just sort of looking at your diet and thinking about, is it sort of balanced? What are you able to eat? What are you able to tolerate with your underlying diagnosis? And really trying to optimize that. So I don't think there's a lot of information around sort of thinning of gut walls. It's all quite early information. And so I'm not sure that there's big changes on that. What we know about intolerances to food and things like hay fever and things is that it may be that estrogen has anti-inflammatory properties. And what we sometimes, some of the endocrinologists that I've talked to do suggest that when you have a reduction in estrogen, that there seems to be an increase in things like autoimmune conditions in that sort of post-menopausal space. So women can suddenly become sort of celiac, or so it may be that there's other conditions. So I wouldn't just assume it's menopause. If you're having a lot of new bowel related symptoms, you should always get that checked out.
Mm, yeah, great
A bit
advice.
of a long answer, but
No,
yeah.
no, perfect. The next one up, someone saying, thank you, Shibani, really informative, and the app looks a really useful resource for clinicians. I'd like to ask about the guidelines for HRT. I'm on estradiol, have I got
Mhm.
that right?
Yeah,
And believe that progesterone could really help my mood and sleep. However, the current guidelines are not to prescribe it to women without wombs. I've heard anecdotal evidence that menopause clinics are experiencing increasing demand for progesterone by women who've had hysterectomies. Yes, any thoughts on that, Shibani?
So again, I think it's really important to think about kind of menopausal symptoms as a kind of a whole. So what are the sort of reasons that may be causing problems? Was it sleep and mood, wasn't it? And
Mm,
for many people, it can be multifactorial. So it wouldn't be that I would definitely go straight to progesterone. I would maybe take a history, think about what other factors. It may be that things like talking therapies, CBT, cognitive behavioral therapy, things like the Sleepio app would be the things that I would probably try first. And I would tend not to use progesterone in that space because I'd also want to think about your other cancer risks as well. So that it looks like there may be a slight increase of cancer, that it looks like from one of the big studies, the WHI study that looked at combination and estrogen only HRT in a non-cancer group of women, it looked like the breast cancer risks were associated more with the use of progesterone than with estrogen. So the combined group had a slight increase in breast cancer risk. Women who were on estrogen only HRT, there were four fewer cancers per thousand women over that period. So it does look like there may be some association. Now, they were older forms of progesterone, which is why some menopause specialists do use it for women. So I think it would be looking at everything as a whole. Are there other factors that maybe cause your poor mood or poor sleep? Can we address those first with non-HRT options? And if really all of those failed, then a short trial of something like progesterone may be appropriate. And if you feel better on a low dose, then it may be something to think about.
mm, brilliant.
I think it's
Thank you.
individualizing the management to what's required, but not discounting the non-HRT options like CBT
Mm,
and sleep management, because I think it's not always that HRT will solve it all.
mm.
And I think it's sort of thinking that actually it's a bit of a lifestyle change and overhaul that's required sometimes.
Yeah, absolutely. And thank you for providing such a sort of balanced presentation on, yes, all approaches. The final question that's come in is around supplements. So you mentioned vitamin D. Somebody's asking, are there any particular supplements other than that that you would recommend? And they've said, I was 40 when I had my surgery, so my menopause was sudden.
Yeah, so I think in the younger age group, it's really important to optimize vitamin D and calcium levels to get the bone density scan. And then based on that, they can your teams can optimize your management of your bone health. So it may be that you need to take a moderate or low dose of vitamin D. It might be a higher dose of vitamin D. It may be that some magnesium is helpful as well if you're having problems with sleep. So I tend to use supplements for a specific reason. I'm not sure that supplements are required for everyone to supplement you if you're eating a balanced, healthy diet. If you're finding that you can't do that for many reasons, it may be cancer-related symptoms, then it might be then specifically tailoring what it is that you need based on what your symptoms are and what might be lacking in your diet. But
Mm,
I'm not sure things like collagen, etc., make a huge amount of difference. And I'm not sure that all of them are particularly well absorbed either.
mm. Okay. Somebody has, yeah, put a little useful tip in for the audience. I found listening to audiobooks really helps me to get to sleep. You can get them from the Listening Books charity, or from your library, for low cost or sometimes for free. So nice little tip there. Thank you for that one. Um, I think the time we've got left, we've got two quick questions, Shibani, and then we will end there. Somebody's asking about magnesium moisturizers. Are they okay to use?
Yes, they're brilliant. So you have a lot of magnesium receptors in your skin. Magnesium moisturizers, Epsom salt baths, fantastic. You can absorb it.
Brilliant. Okay, nice and snappy for that one. That's brilliant. And finally, yeah, I suppose, yeah, very topical, GLP-1s. So I suppose we're talking about the weight loss jabs here. are they okay to combat weight gain, specifically in the context of this audience?
So again, I think if you're thinking of using them, it's really important before you start to speak to your oncologist and your clinical teams to make sure that it's something they would be happy for you to use. Broadly speaking, we haven't seen any data that suggests there's an increased risk of ovarian cancers. There may be some benefits from using them in preventing certain cancers or weight-related cancers, but I think it's really important that you, before you start using them, that you just speak to your oncologists, get advice to make sure they're happy for you to start on them. For some patients, they can be a really helpful way, but it's just really important to get that sort of advice before you start. And if you are on oral HRT, it may affect the way you absorb it, and so going on to like a patch or a gel may be important if you're on the GLP-1s.
Brilliant. Thank you so much, Shibani. And certainly I hear in a lot of your answers there, if not all of them really, that what we're talking about is highly individualized. Definitely your own team are best placed to give you, a sort of tailored approach. But hopefully our audience has found all of that extremely helpful, as I have. This session will be made available on our YouTube channel and on our website. So if you haven't managed to, frantically take notes, please don't worry. Everything will be captured. And just a huge thank you again to Dr. Shibani Nicum for really generously providing this session for us today.
Thank you so much
lovely
for having me.
Come in.
Thank you.
Thanks, Shibani. Take care, everybody.